Hi guys, looks like the picture's a little bit fuzzy, but as long as you can hear me, that's the main thing. I'm going to start off with the respiratory system first, so it's that pulmonary and thorax. So again, just kind of trying to keep it simple. Looking at no matter what health system, again, we're talking about lungs, cardiac, neuro, you're always keeping in mind that general health history. Is it the most important thing to get if somebody's coming in with certain things? No, when somebody's coming in real respiratory distress, or you think they're having a heart attack, or they've been in a traumatic accident, I don't have time to get a full health history, right? I have to address that immediate life-saving issue first. However, that health history at some time should come into play because, again, by looking at that health history, by looking at medications, looking in the chart, it will be able to guide you to know what that person's health conditions maybe they have been facing for a time period, right? Because again, you can look at it and see if somebody's on inhalers, and that should automatically say, hey, they've got like a COPD or asthma kind of diagnosis that would be chronic. All right, looking, assessing, do they smoke, things like that. Again, one of the things with respiratory is that functional ability. So are they having an increase in shortness of breath that is limiting or changing their functional ability, their activities of daily living? So that key again going, hey, you know what? Can you tell me, are you having shortness of breath when you get up and exert yourself, or like when you try to walk? Or again, I've heard patients say, I climb my stairs and I have to sit down and rest right away. So it's that kind of thing that you're keying in on. Again, when we are looking at laboratory and diagnostic testing, there are different things, and we talked about sputum samples and blood work. And so again, you're going to hear a lot about taking samples. So excuse me, if I had a concern that somebody had a urinary tract infection, I know I'm going to need to get a urine specimen. With this being respiratory, we talked about sputum because it's going to be sent for what they call the gram stain, because you need to know what you're dealing with. Like again, what is that identifying object that could be causing that infection so that the treatment can be ordered to target that identified source, that bacteria or that virus or that fungal. Okay. All right. So again, we talked about those areas where you have, again, thinking about front and back, anterior, posterior, that bronchovesicular or over that main bronchi. So you've got your trach, and then kind of at that bottom, there's your main bronchi before it starts to branch off, right? So bronchovesicular, the largest portion of the lungs, so the largest portion of those lung tissues, those are vesicular. And then over the trach, you would hear bronchial sounds. It kind of makes sense. So bronchial sounds. So you should kind of know, hey, if I'm listening over the trach area, I should hear bronchial and not vesicular sounds. Or if I'm listening over the bronchi, or where I would anticipate, or getting over that trach, and where I anticipate bronchial sounds, I should not be hearing vesicular sounds. So not that we get into why you would hear those abnormalities. We don't go into that here. It's just knowing that what do I hear here, what do I hear at the main, and what would I hear in the rest of part of the lungs. Again, a couple of the landmarks that you know, again, is that clavicle and the suprasternal notch. And then when you come down to the suprasternal notch, a little bit under there is the manubrium, or they call it the angle of Louis. Suprasternal notch, yeah. So we'll talk a little bit more about that in cardiac, but again, I think the clavicle and suprasternal notch is the kind of most important for respiratory right now, because again, thinking about where are we going to assess those anterior lung sounds at 1 and 2. Make sure again that you are a little blurb about the costal margin on the front. Again, the front at the lower spot of the ribs is at 90-degree angle. And then your clients that have a COPD or that barrel-shaped chest, they are going to have a larger costal margin. The respiratory conditions, again, like COPD, asthma, emphysema, atelectasis. Again, guys, you don't have to memorize each of those. Just so you know that, like your COPD, which is the chronic obstructive pulmonary disease, a lot of times you're going to get that from smokers. That's probably that highest causative factor. However, you can have chronic emphysema that kind of will get under the COPD, sometimes chronic bronchitis, something of that nature. So that's probably really all I would say about the respiratory conditions. The other thing too, when I'm looking at the anterior and I'm looking at the posterior, again, I'm looking at symmetrical, left to right, right to left, just side to side. And I'm looking to see, is that chest wall rising rhythmically equal? Do I see one side elevating while one goes in or doesn't move? And they kind of call that like a seesawing. Do I see the those accessory muscles, which you can really see somebody who's struggling to breathe? Okay. Oops. Okay. Again, abnormal lung sounds are adventitious sounds. So whether you're hearing wheezes or rails or ronchis or crackles, those are adventitious lung sounds. We listen to lung sounds with the diaphragm of your stethoscope. Again, in the posterior, I'm looking at the back to see, again, do I see symmetry? Do I see any kind of like abnormality in the back? Do I see a misaligned spine, or does the spine alignment seem to be straight? Okay. Again, there are 8 spots on the front anterior you're listening for lung sounds, and there's 10 spots on the back. So my best recommendation, guys, is you really do have to get into your book. You absolutely need to read what is the description of crackles, rhonchi, wheezes, pleural friction rub, and stridor. Okay, associated with each of those guys, you'll see a little blurb about when would you hear crackles. And like a lot of times crackles come with people who have pneumonia, because you've got that fluid sitting in those alveoli and you can hear that. With wheezes, to me, that can be your COPDers, but like an asthma or an emphysema. Some of your respiratory conditions, you can have one or more adventitious sounds. So like COPDers, a lot of times can have rhonchi and wheezes. Let's see. Keep in mind the plural. Oh, I know, I was going to tell you crackles. Some kind of old terminology, they call those rails, R-A-L-E-S. We really kind of knew as crackles. If you take your hair between your fingers and do this, you kind of hear that crackling sound. That's almost what your crackles would sound like. Or if you ever were at like a campfire and you hear the ashes or you hear the wood kind of crackling, that's what it kind of sounds like. There's various, you can have high and lower pitch, which you don't have to get into that depth, but again, you need to know what does it sound like. What disease conditions would we anticipate seeing these in? And then stridor is a medical emergency, because stridor is going to be that there's something obstructing that airway. Okay, so whether it has totally blocked off because they're having some kind of allergic reaction, somebody has swallowed something, but it's really an occlusion, and you really hear that high pitch, like I said. Please, please make sure you go and listen to those links that you can listen to those adventitious sounds on. That's probably your best thing, because crackles and rhonchi can be kind of hard to distinguish between. They say rhonchi almost sounds like a snoring. And again, you can have some kind of louder and lower of the rhonchi, so, or coarse or fine. So like I said, listen at a couple different rhonchi sounds, and that's really your best bet, because those two are really, I think, the hardest to really try to get under your belt and know about. Okay. Anterior, posterior. Again, when you're looking at that thoracic cage, we're looking to see if and it's on page, or I'm sorry, slide 21, where it talks about anterior, posterior. So again, if I took my hands and I put one hand right here, right behind the back, and one here right at the anterior, like around the breast area, and the diameter should be like this. When I come to the back, I should be able to place my hands on a normal back, this side and this side. So they're saying that this way, 1 to 2 on the back is a normal anterior, posterior, or AP diameter. In your barrel-shaped chest people, that barrel-rounded shape, their AP diameter is like 2 to 2, or it might be even larger because you've got that barrel shape. On slide 23, the patterns of respiration, again, what would normal look like? And because on these patterns of respiration, guys, when you work on a unit that has a telemetry, somebody's hooked up to that monitor and their breathing is being evaluated, you can catch like the waveform or the respiratory form. So you may, these are like maybe more ICU settings where you're looking at the respiratory pattern. So the rate of normal, 12 to 20, right? Bradypnea, less than 12. Tachypneic, greater than 20. And then hyperventilation is faster than 20, but it's a more deep breathing, like when somebody's hyperventilating, like people who have panic attacks, hyperventilating, that's when you would see more of a hyperventilation. Tachypnea is, like I said, it's fast, but usually tachypnea is from an underlying medical condition that's going on, okay? So you should be aware with what those 4 patterns look like. I would not concern with those other ones, okay, because that's kind of higher level right now. When it comes to older clients, go back into the book and keep in mind what are our older clients at risk for. They're risk for that atelectasis, aspiration, but again, remember we talk about how this, so many changes with our geriatric that we've talked about over the course of these few short weeks. The skin becomes less elastic, they lose muscle, so, and then like the abdomen can be less musculature, right? They lose it, and that's normal for the aging process. Another thing also for the lungs in the aging process is that sometimes the lungs can become stiff. They may lose the kind of that elasticity that can be in the lung tissue as well. So we know things decrease. Okay. That is it pretty much with respiratory. So again, those lung sounds, the causative factors, those respiratory patterns, what is barrel-shaped chest, okay, a little bit like with COPD. Also, we talked about tripoding, and that is when people are going to be in an upright position. A lot of times in a sitting, like in a chair, they're leaning over, their arms are on their legs, and they're just hunched over. A lot of times too, you can see a pursed lip breathing, so that's tripoding, and that again is a very characteristic of COPDers. Okay, so now we're going to jump over to abdomen, and again with abdomen, it's with that GI tract. You hear that a lot, abbreviated GI tract. Let's see. Okay, so again, you know, that health history can be very good in assessment and data, but again, you're going, do I have time to really dig? How much history do I have time to get from a patient, depending on, are they coming in this emergency situation, life and death, or maybe they're in such excruciating pain they really can't answer questions appropriately at that time. But just kind of go back over again with that health history. What were some of those things that we do want to assess and ask for that can really give you a pretty good idea of maybe what that patient is dealing with, okay? Again, slide 5 talked about our older clients. So there are, again, things slow down, right? And so we talked about how their gastric motility, which is just that natural, kind of like that peristalsis, those wave-like contractions, digestion, that decreases. Their saliva and stomach acid decreases, okay? Again, with those changes that occur, your older clients will be at a higher risk to develop constipation, digestive issues. A lot of times they may have difficulty swallowing. Let's see. With an urgent assessment, and go back in there. Let's see, it looks like page 547, hopefully in Jensen, where you really know an acute abdomen. So again, acute, new, quick, sudden onset can be life-threatening. And I cannot stress enough that you have to know your abdominal landmarks. Draw those 4 quadrants. What are in each of those 4 quadrants? Because again, somebody could be coming in an acute attack, and it could be that their appendixes are ready to burst, right, or rupture. Gallbladders can rupture. Somebody could have a complete intestinal blockage. Somebody might be coming in with an acute GI bleed. So those are those really life and death situations, okay? All right, slide 8, it had kind of began breaking up into those quadrants and showing some of the organs that are involved in each of those areas. So thinking in mind, guys, when you're looking at that abdomen, what am I looking at? So when you're really assessing, when we say the abdomen, we know in those landmarks, there's the liver, and there's the gallbladder, and there is the, all within that abdomen. Maybe I cannot feel it, but I do know the kidneys are there, the bladder's there, the uterus actually is there too, ladies, ovaries. So there's a lot. And then think about the whole colon. So you got the ascending, transverse, and the descending, and you got the sigmoid colon, right? So there's a lot that we really are taking into account of. And so make sure you go back to page 544 and 545, box 20.2 and figure 20.3. Remembering those kidneys are really more in the posterior, kind of at the lower part of the rib cage, and in the back where that angle is, again, like the costal margin, you have that costovertebral angle in the back. And a lot of times these folks that have kidney infection or kidney inflammation will have what they call a CVA. It's just the abbreviation for costovertebral tenderness. And by kind of putting your hand there and thumping on it, it can reproduce quite a significant pain because of that inflammation that they have. When you're assessing the abdomen, again, it's best to have the patient as supine as possible. Sometimes it just depends. Sometimes the patient may bring their legs or knees up, okay, with the feet flat on the bed. If that might be, if they have like a really, I don't know, abdominal pain or something, that might be the position that they can get relief in for you to assess them. So again, you are looking for any nonverbal signs when you're assessing that abdomen. We're looking on your assessment, you have a word called guarding, and I did not get to talk to everybody today. You're looking for these patients to either splint or guard, and that means they are either like put their arms over their stomach because that pressure might help them, or they kind of take their hands and they guard themselves because they're in so much pain they don't want you touching them. So those are those nonverbal cues. Or again, if they're pulling their legs or knees up because that's helping them, those are those nonverbals that you're really looking for. Okay. Abdominal inspection, what are you looking for? So you're looking at the color, the umbilicus, can you see any bulges or protrusions or masses? And take a look at those pictures of the abdomen. One was very rounded and one was very flat. The rounded one was orange, and that was an example of somebody who's jaundice. And again, going back to there's some kind of underlying liver disease that's going on. Okay. Okay. I keep trying to advance the PowerPoint slide on the computer here, so I keep trying to go like this. I'm sorry. All right. We showed a picture of quite a big umbilical hernia with the Valsalva maneuver. So again, that Valsalva maneuver is something that when you're bearing or straining down, like thinking if you were having a bowel movement, and that pressure will make that hernia protrude out. Okay, again, make sure you look at the inspection of the abdomen for abnormalities. I can have, on slide 13, I can have that obese abdomen. Doesn't mean that it's really so much an abnormal, it's just that that person is obese. But again, if I was to palpate that stomach, it should still feel soft, a little bit squishy, right? Versus the person that has that ascites. And again, that ascites is fluid accumulation that's going to be in the abdomen or the peritoneum. And that abdomen is going to be extremely firm. And like I said, that's going to go again that there's some kind of underlying usually chronic medical condition that's going on, whether it's liver, heart failure, or something like that. Okay. Again, just some terminology. Hepatomegaly is enlarged liver. Splenomegaly is enlargement of the spleen. Cholecystitis means an inflammation of the gallbladder. And cholelithiasis is gallstones. And something too, if somebody came in with a large liver, one of those screening questions, or to look in that patient's history, is if they have any alcohol abuse, and going, okay, when was your last drink? How much do you drink a day? What was your last drink? Because that's important to know. Auscultation of the bowel sounds. Again, you're going to start in one quadrant, rotate clockwise. You are listening for one sound approximately every 5 to 15 seconds. If there's absent bowel sounds, again, you are required to listen for 5 minutes per quadrant before determining that no bowel sounds are noted, before you can really document that. What bowel sounds should sound like they can be these high-pitched gurgles or clicks. A lot of times for normal sounds, it's more kind of be like a soft gurgling. If you have hyperactive bowel sounds, and again, guys, go on YouTube and Google what bowel sounds sound like. Hyperactive usually comes from someone that's going to have is having diarrhea. Maybe they have an inflammation in the stomach. They have like what they call gastroenteritis. Maybe they have a food poisoning, and that fluid, that fecal matter comes through the GI tract so rapidly. That's when you can hear a hyperactive. And like I said, if you have somebody that's having a decreased peristalsis, or maybe they have some issues with a constipation, then you're really hearing like more hypoactive. And then the absent bowel sounds generally is going to come from somebody that has an obstruction, or what we call an ileus, or paralytic ileus, I-L-E-U-S. Read a little bit about that. So with these ileuses, what happens is that the peristalsis really slows down or can cease. There's medications that can cause that. Anesthesia can cause it. Other imbalances within the body can cause it. So the idea is we want that peristalsis to keep going. That's what's moving everything through that GI tract. Okay, on auscultation, we said there's 3 things that I want to make sure that I'm listening for. A, are bowel sounds present? Yes or no? And what do they sound like? That active, hypoactive, hyperactive, or absent? Okay. 2 was the frequency, and I already kind of answered that. Frequency is active, hypo, hyper, or absent. And quality, are they high pitch? Are they dull, tinkling, distance? Sometimes it sounds like they're gurgling or rumbling kind of sound. Again, kind of normal bowel sounds when you're listening can be, like I said, it's almost like that, kind of a soft gurgling, kind of a clicking. It's kind of an irregular pattern. Okay. This is the 1 time 2 that is very important. We said the order and how we are going to assess our patient is, this is the only time it's going to fall out of a different order. For abdomen, inspect, auscultate. You're not percussing, but then you would palpate. Palpation, light, 1/2 inch, finger pads of the finger pads, right, of the finger. And you're just going across each one of those 4 quadrants. With light palpation, you're asking the patient, is there any tenderness, pain, and you're watching their facial expression for any grimacing, or you can tell if they're guarding or splinting because they can be in quite significant pain. So again, we listen before we palpate because we don't want to distort any kind of bowel sounds or manipulate. Okay, so inspect, auscultate. Keep that in mind. Okay, so again, I'm just looking at slide 21 where again it breaks it up and just shows you the 4 quadrants with right and left upper, right and lower, and a little bit again of what is under each of those quadrants. So that's really the biggest thing. Again, on slide 22, it talks about palpation, and so assessing for cholecystitis and assessing for appendicitis. Take a look at that because there's that, and then there's specifically for the gallbladder is Murphy's sign or Murphy's test. That is trying to assess if somebody has a cholecystitis. For the appendix, that is the McBurney's point. You're testing McBurney's point, so make sure you go back and read it and watch those videos of how you would assess for it. Okay. We talked a little bit about swallowing difficulties, and that was dysphagia with the G. Sorry. Some other common problems we talked about kind of already is with when it gets to the GI tract, laying is again with that liver, it can be hepatitis, it can be cirrhosis. People, excuse me, can have issues with their pancreas, and they can actually have a quite severe inflammation infection called pancreatitis. And then again, appendicitis. So again, Murphy's for gallbladder, McBurney's point for appendix. And I think that's it. All right, guys, if there's any questions, make sure you just send me an email. Have a great week.